diseases of the pleura, and it's basically an overview. I certainly can't cover all the topics, but hopefully it's going to be a nice overview of pleural disease. Just wanted to start a little bit with pleural anatomy. So as we all know, the pleural space is bound by the visceral and parietal pleura, and it's the visceral pleura that covers the lungs and forms the interlobar fissures. The parietal pleura covers the mediastinum, the diaphragm, and the inner surface of the thoracic cage. So with regards to the layers of the chest wall, so you have the lung, you have the visceral pleura, parietal pleura, between that is the pleural space. Then superficial to that is extrapleural fat, then endothoracic fascia, and then the intercostal muscles. So I thought this was a nice diagram showing just that. So again, lung, the pleura, the extrapleural fat, the endothoracic fascia, and then the intercostal muscles, as well as intercostal fat and vessels.
They're asking for a little more volume on this.
Oh, okay. So this is a bit of a breakdown of what I'll be talking about today. I put pneumothorax there, pneumothoraces, just for completeness sake, but I'm just going to skip that altogether and start with talking about pleural effusions. Then I'm going to talk a little bit about infection and pleural disease, benign and malignant pleural tumors, and then mimics of pleural neoplasm, as well as fistulas that involve the pleura. So with regards to pleural effusions, so the typical amount of fluid in the pleural space is usually about 5 mils or so, and when there's an excess of that, it's compatible with a pleural effusion. Pleural effusions are divided into exudative and transudative. Exudative effusions occur because of increased capillary permeability, whereas transudative occur because of increased hydrostatic pressure or decreased osmotic pressure. Exudative effusions tend to actually show pleural enhancement. They don't have to all the time, but they usually do. There are various criteria for exudative effusions based on analysis of the pleural fluid. I won't go into them, but they relate to the amount of protein within the pleural fluid versus the serum, as well as LDH levels. And I just added that on radiographs, it takes about 50 mils of fluid to cause blunting on a lateral chest X-ray, blunting of the costophrenic angles, whereas it takes about 200 mils of fluid to cause blunting on a frontal radiograph. And the lateral decubitus is actually the most sensitive and can detect as little as 10 mils of fluid. These are some of the causes, the exudative and transudative causes of pleural effusions, as we all know. So some of the common exudative causes include infection, neoplasm, infarct, and inflammatory disease. Some of the transudative causes include CHF, hypoalbuminemia, cirrhosis, nephrotic syndrome, and other renal disease, as well as constrictive pericarditis. So that was just a brief sort of introduction, starting with pleural effusions. I'm not going to get into some of the complex pleural effusions. You can have chylothoraces as well, but I won't get into that. So next we're going to talk about infection and pleural disease. So there's one source that I read that really I thought organized things well with regards to infection and pleural disease. They talked about sort of 3 stages. The first is what we would consider a simple peripneumonic effusion. Second would be an empyema, and the third stage is compatible with fibrothorax. And they stress that you don't necessarily have progression through all 3 stages with regards to infection, but it's a nice way of characterizing them. So the first stage is a simple peripneumonic effusion. It's also called an exudative stage, and that's when there's increased permeability of the visceral pleura secondary to a pneumonia. And at this point, the pleural fluid is still sterile. It can be associated with pleural thickening, and something called a split pleural sign can be seen in this, and that's when there's thickening of the visceral pleura, thickening of the parietal pleura, and then fluid in between. And these simple peripneumonic effusions usually resolve with antibiotics. So the second sort of stage of pleural disease and infection is empyema, and at this point the pleural fluid is infected. And some of the classic CT findings of empyema include an elliptical, so a pleural collection that has an elliptical shape in a non-dependent location. It's usually sharply demarcated from the adjacent lung. And you can see again that split pleural sign where you have pleural thickening and enhancement. And the thickening tends to be smooth and uniform. And there's usually displacement of the adjacent lung versus destruction. And this is an example from our institution of an 86-year-old male. And you can see that there's a pleural collection here at the base. And there's pleural thickening, there's enhancement, and then lower down you can also see that there are locules of air within the collection, and again some thickening. So this is compatible with an empyema. And I just wanted to differentiate between lung abscess and empyema, and we see this in textbooks quite a bit. I think it's nice to sort of have an idea of how to differentiate the two. So lung abscesses tend to be round, whereas we said with the empyemas, they tend to be elliptical. Lung abscesses tend to be ill-defined with shaggy walls of irregular thickness, whereas empyemas tend to have smooth thickening. And lung abscesses usually cause destruction of lung versus displacement of the lung. So this is an example from the literature of a lung abscess. So you can see that it's more round in appearance. It has an air fluid level in this case, and then again, the thick, irregular walls. And then sort of the third stage of pleural disease and infection is the organization stage. And this occurs in patients with chronic empyemas. So there's an ingrowth of fibroblasts and organization that can result in extensive pleural fibrosis and development of fibrothorax. And it tends to be smooth pleural thickening, as well as thickening of extrapleural fat is usually seen. There can be calcification associated with this, and it can become quite extensive and most commonly associated with TB, post-TB infections. Now, this sort of diffuse pleural thickening can also result from other entities. For example, secondary to asbestos-related disease. Post-hemothorax or also can be seen in collagen vascular disease, so it doesn't necessarily just occur because of infection. And just a little note on pleural calcification. So, like we said, it can be associated with this pleural fibrosis, regardless of the cause, and most commonly seen with healed TB or bacterial empyema, post-hemothorax, and asbestos exposure. And just a little note on talc pleurodesis. So talc is a sclerosing agent used in treatment of chronic pleural effusions and pneumothoraces. And it's sort of a mimic of calcification within the pleural space. What it really is dense accumulation of talc within the pleural space. But it is something that we think about in the differential. This is just an example from the literature, but benign diffuse pleural thickening, and it's mainly seen anteriorly, laterally, and posteriorly in this image, and it's bilateral in this case. So I'm going to touch a little bit on benign pleural tumors. So what I have included here are lipomas and fibrous tumors, but fibrous tumors can be both benign and malignant, so I'm going to talk about them under the malignant category. So we're just going to touch on lipomas here. So I don't know if this projects very well. The lipoma is located here in the left aspect. So the lipomas are rare benign pleural tumors. They typically are uniform with fat density. They can have linear soft tissue strands within them as well. And so just moving on to pleural malignancy. So the most common malignancy to affect the pleura is metastatic disease. You can also see mesothelioma, which we commonly discuss, and fibrous tumors. Those are the three main malignancies that I'm going to talk about, but you can also have pleural involvement by Kaposi sarcoma and invasive thymoma, as well as very rarely liposarcoma. I guess if you can have a lipoma in the pleural space, you can have a liposarcoma as well. So with regards to pleural malignancy, there are CT features. There are 4 features that favor malignant disease that we learn about. One is nodular pleural thickening, mediastinal pleural thickening, so that's thickening of the pleural surface along the mediastinum, thickening greater than 1 centimeter, and circumferential pleural thickening. So with regards to pleural metastases, so again, they're the most common malignancy involving the pleura, typically result in a pleural effusion, and CT appearances can be variable depending on sort of the stage of disease. So you can just see a normal pleural effusion without any pleural abnormality otherwise. You could see smooth thickening early on. You could see localized masses or gross nodular thickening, as we discussed. And the primary tumors that metastasize to the pleura, lung first and foremost, then breast cancer, and then lymphoma. And then you can have other cancers as well, including pancreatic, kidney, and colon cancer. This is an example from our institution of a 73-year-old female with a history of breast carcinoma. And you can see here, so there's circumferential pleural thickening, nodular thickening, and there was actually fissural nodularity as well. And another thing to appreciate here is that there's volume loss of the right hemithorax versus the left, and that can be seen in extensive pleural disease. So with regards to malignant mesotheliomas, they're highly aggressive neoplasms with a poor prognosis. Peak incidence is around age 60. Most cases are related to prior asbestos exposure, and the latency between time of exposure and development of mesothelioma is quite long, in the order of 20 to 40 years. So some of the common findings on CT predominantly is nodular concentric pleural thickening is highly suggestive of malignant mesothelioma. With early disease, the thickening may be more localized and discontinuous. Ipsilateral pleural effusion is usually seen, and involvement of the fissures is common. As well, other things to look for include chest wall invasion and distant metastases, and you can see calcification related to malignant mesothelioma as well. So this is an example from our institution of a 56-year-old male, and you can see again it's marked circumferential pleural thickening, it's nodular, it's very thick, in the order of 2 centimeters in some areas. And in this case, the patient also had parenchymal nodularity, and you can see the fissural thickening nicely here as well. So moving on, we're going to talk a little bit about fibrous tumors of the pleura. So about 30% are malignant. I've read different sources, between 30 and 40%. They aren't related to asbestos exposure. They usually arise from the visceral pleura about 70 to 80% of the time. They also can be associated with hypertrophic pulmonary osteoarthropathy and hypoglycemia. And they tend to be focal pleural mass, tend to be solitary and fairly well defined. And they generally have a good prognosis. So this is an example from the literature of a fibrous tumor. So again, smooth lobulated mass abutting the pleural surface, solitary. So next I'm just going to talk about some of the mimics of pleural neoplasm. So the first entity I wanted to talk briefly about pleural plaques. So pleural plaques are the most common manifestation of asbestos exposure. They're areas of dense hyaline collagen, usually bilateral and asymmetrical, more common on the left and have a posterolateral predominance. And you can also see something called hairy plaques, and that's sort of the plaque and then these radiating interstitial lines within the lung parenchyma, and the significance of this is unknown. It's just something that can be seen on imaging. So this is an example from our institution and one from the literature as well. So see well-circumscribed area of pleural thickening with associated calcification. Pleural plaques tend to have thicker edges than the central portion. I think that's depicted better on this example from the literature. So you can see that this calcification on the lateral edge is thicker than the central portion. And pleural plaques can progress in size, extent, and calcification over time as well, which is important to know. And this is just an example of the hairy pleural plaques that I was talking about, so hopefully that projects well, that you can see those interstitial lines radiating perpendicularly from the pleural plaque itself. So the next mimic of pleural neoplastic disease I'm going to talk about is rounded atelectasis. So rounded atelectasis tends to be round, peripheral, pleural-based mass that abuts an area of pleural disease, and that's important. And as well, you can see bronchovascular markings that curve into the lesion, so-called comet tail sign. Air bronchograms can be seen within the mass. They usually are seen posteriorly in the lower lobes, can be found in other areas of the lungs. And contrast enhancement is usually homogeneous, which you would expect for atelectasis. Alright, so this is an example from our institution on the left, and then an example from the literature. So this is a 57-year-old female, and she had some pleural scarring and thickening at the left base and in the region of the lingula. And so you can see that there is this rounded opacity here abutting the pleural surface, and it's abutting an area of pleural disease. And then faintly you can sort of see the swirling of the bronchovascular markings as well. This is in the lingula. I just showed this from the literature just because it's a larger area of rounded atelectasis, but again, you see the swirling vessels. And lastly, with regards to mimics, I just wanted to touch on pleural pseudotumors. So pleural pseudotumor is when there's pleural fluid within an interlobular fissure. So it can appear ovoid or oblong with tapering ends that lies in the fissure and has obviously fluid attenuation. I don't think it's so much a mimic on CT as much as on plain radiographs. And this is just an example from our institution. So in this patient, there was pleural fluid that was tracking through the fissure. And I think it would be more impressive on a chest radiograph. However, this patient didn't have any in this time point. So lastly, I just wanted to talk a little bit about fistulas that are encountered with regards to the pleural surface. So classically, bronchopleural fistulas, something that we learn about. So that's a communication between the pleural surface and airway or the lung parenchyma. And the causes can be varied. It can be secondary to thoracic surgery, secondary to infection, secondary to malignancy, or medical intervention. And a persistent pneumothorax or hydrothorax is suggestive of a bronchopleural fistula. And sometimes on CT we can demonstrate a communication or track from the airway or the lung parenchyma to the pleural surface. This is an example from our institution of a 62-year-old male, previous empyema on the right, previous right thoracotomy and decortication. And so you can see that there's this pleural air-filled collection, and faintly you can see that there's a communication between the airway and the pleural space, and this is a chronic finding. Another interesting example from our institution, so this is an example of a pleurocutaneous fistula, which wasn't anything that I had seen before doing this presentation. So it's a 58-year-old female, history of chronic chest infections and empyemas. And so she had a moderate left-sided pneumothorax and significant left-sided subcutaneous gas. It was a chronic finding, and I don't think in this case they could see a definite track, but it was felt to be on the basis of a pleurocutaneous fistula because of the chronicity and the striking findings as well. And this case is really, I think, interesting. It's also from our institution, and it's an example of a colopleural fistula. So it's a 40-year-old female, and she had right diaphragmatic hernia repair, as well as resection of part of her right hemicolon. And so what these images are depicting is this is part of the large bowel containing oral contrast, and then a few cuts up you can see, again, bowel with contrast. And then that connects with a large air-filled cavity within the pleural space on the right, and it's having mass effect. I thought this was an interesting one because you can actually see the oral contrast layering posteriorly in that collection. And so basically what I hoped to achieve was not to cover everything. I mean, obviously it's a very large topic. You can't cover everything in pleural disease, but just to give sort of an outline of some of the main entities and to provide a framework. And those are some of the references that I used. And just wanted to thank you and also thank Dr. Berganker for supplying me with some of the interesting cases from our institution. And that's everything. Any questions? Go ahead, Beth.